I know we have exceeded time by 10 minutes. I'll invite Dr. Alan Lumsden, who is the president of the International Society of Endovascular Specialists, which the society which actually got us started with this society and has been with the Vascular Society in all its meetings. Dr. Lumsden is a world champion and an opinion leader and on robotic interventions. He's the one who's done seminal researches and developed a lot of protocols, and his special interest is endovascular intervention by robotic using the robot. He's going to enlighten us on robotic endovascular and pulmonary interventions and also show us a case, which is a live in-box case on treating embolizing endoleaks. Dr. Lumsden, over to you.
Wonderful, thank you. It's been fascinating listening to the presentations this morning. So the challenge you gave me was the title was Robotic Cardiac and Endovascular Interventions Looking Through a Crystal Ball. And I've been trying to look through this crystal ball for many years now, but I believe there is some motion that's actually taking place. And let me show you, start off with, this is my operating room. And so we're very interested in robotics. We created an organization called the Methodist Institute for Robotics, Imaging, and Navigation. And really it serves to emphasize I think if you have imaging alone, it takes you to a certain level. If you have robotics alone, it can take you to a certain level. But the holy grail is being able to integrate the imaging into the robotic control system. And hopefully we can encourage you this morning that there's some hope on the horizon. If you look around this room, I gave this at the Hamlin Institute for Robotics in Imperial College last year. And in this operating room, here is a robotic transcranial Doppler that automatically picks up a middle cerebral artery signal. This, of course, is the Pheno from Siemens, which is a robotic arm which came out of the car assembly industry. This is the intuitive surgical XI robot. And so let me just kind of go on and say, but when you come down to catheter robotics, really what we're talking about is in the past it's been Hansen. And we published a whole bunch of different articles related to the use of Hansen. This was really the first foray into the use of robotics inside the cardiovascular system. It was initially introduced really for use in AFib ablation. And that's really how I got involved in it. When I could see electrophysiologists in a beating heart move this catheter 1 or 2 millimeters to the right with a known amount of force being applied to the wall, and that was very important. We took it from there, basically, and then used it in a whole variety of different settings. And actually, we're very enthusiastic about Hansen. I was the PI, really, on the first trial that led to the robot being approved for clinical use, basically, in the periphery. And you can see that there was a journey that spanned a course of about 6 or 7 years in trying to get this technology to actually work. And that was the first in-man study that actually led to approval of the robot, basically, in the periphery. Okay, so let me try and play catch up a little bit. Is that let me go back to the beginning. So you can see this picture of the operating room now. Okay, all right. So just a quick rundown on the operating room. These are a number of different robots that are in my operating room. This is a robot that acquires transcranial Doppler signal. This is a Pheno. This is the Intuitive XI. This is the new Corindus robot, and this is a remote viewing robot. I'm going to skip forward a little bit. Try and catch up on some of that time. The first introduction to catheter robotics, of course, was Hansen Medical. And it was really introduced for treatment of AFib. And it was through working with our electrophysiologists, actually, that we got interested in this. And that led us to be heavily involved in the development of the peripheral robot. We used it and published for a number of different situations. You can see we embolized an ascending pseudoaneurysm. We used it for treatment of pulmonary artery stenosis after lung transplants. But what we're particularly interested in is the fusion that would take place between imaging and robotics. And this really was the series of publications, and some of these involved Nick Cheshire's group at Imperial College, which led really to the first in-man study that led to the approval for the Hansen robot base in the periphery. Some of the advantages of this were, and this was a study done with the Imperial College group, was it minimized the amount of wall contact. What we were always particularly interested in is, could we navigate over an aortic arch and result in no contact with the wall. Well, the reason we get embolization is because even the best interventionist depends upon a series of wall contacts to actually move from groin to target. And when you do that over the aortic arch, it necessarily has some risk associated with it. So let me just show you this example. This is a patient who'd had 2 attempts by outside physicians at doing a renal artery stent. I'll let this run. And what we've done is they fused the image. You can see the center line trajectory. And what we did was use the robot to line up the wire and stent. And when we knew the trajectory we needed, and with the first pass of the robot, we managed to pass that wire straight down and into the renal artery and stented it.
Alan, I think we need to finish your talk in another 9 minutes. So just be...
Okay, sure. My second talk won't take that long, actually. Okay. So let me go through this a little bit. Now, here was kind of the holy grail, and really what we were trying to do was, can you do fluoroless navigation? This really built electromagnetic sensors into the robot catheter. You can see underneath the fluoro table or the field generator. And what this essentially allows you to do, when you put these sensors at certain points along the catheter, you can model that. You can model that basically from the electromagnetic field. So you can actually demonstrate a virtual catheter. So here you're actually navigating, not in vivo, but ex vivo in an animal model where we actually can model the catheter simply by detecting where these electromagnetic sensors are basically within the field. And that was an example of how this was essentially set up. So these are all very promising developments. What this is autonomous movement using a thing called autopilot. So we would take the CT scan, we'd mark where the renal artery orifice was, and essentially program a glide path into the robot. And that robot would track autonomously, much like basically a fighter pilot does basically when firing a missile. We'd interrogate the renal artery orifice and would autonomously move into that. And so it was this combination of flexible robotics, electromagnetic tracking, and taking a center line. We all think of center lines for measuring devices, but this center line can be imputed basically into a robotic control system. And you can see that these catheters would actually start moving autonomously. So we were very excited by the ability to do that. So then what happened? So what happened was overnight, Hansen was purchased by Auris, and Auris is another robotics company. They felt that the clinical pathway to getting approval was actually much faster in the endobronchial arena. And essentially, this is exactly the same robot that is now being used, and his FDA approval was just purchased by J&J for something like $4 billion. So clearly it was the right decision for the company, but it's essentially exactly the same technology. And we hope at some point in time, Hansen will re-engage basically into the endovascular world. So what happened going forward? So where we're at now is with Corindus, and Corindus actually doesn't have near quite the same capabilities as the Hansen robot has. It was designed initially as a coronary intervention, but we've become particularly interested in it for the opportunity of treating stroke. This is the first time in a model where we actually started navigating in a cerebrovascular model. This is Dr. Gavin Britz, who's the chair of neurosurgery here. And you can see that where we've become particularly interested in is the application in mechanical thrombectomy basically inside the brain. And this is an example.
Exercise,
we'll let Gavin talk.
Robotically manipulated the microwire and the catheter into the internal carotid artery. As you can see now, the microwire is inside. We're now delivering the microcatheter and pulling the wire back robotically. At this time, an intracranial run was then done, demonstrating the RETI. We then went ahead and navigated the external circulation, even through a disease segment.
So let me just, in the interest of time, kind of move forward. And so this is another example of how a thrombectomy device can be delivered by the robot into the head and potentially can be utilized for mechanical thrombectomy. Now, why this is important is we said this is our setup in our operating room. We sit outside the operating room. You don't get any radiation. But here we are actually tethered to the control through cables that actually run from the control system into the room. But what we're particularly interested in is being able to do this remotely.
And we are in the circumflex up here, guys. Good. We are just beyond that brain.
So that's Ryan Mudder doing a remote coronary intervention. And as you know, the first remote human coronary intervention was done in India. And that's a very exciting application. We believe in what the whole focus. Corindus has now been purchased by Siemens, which I think is the holy grail in being able to tie the robotics to the imaging system. And a lot of the focus now is, can we use this for mechanical thrombectomy? It's clearly been established that for ischemic stroke, the treatment is mechanical thrombectomy. The problem is that therapy cannot be delivered. And so what we're exploring is being able to navigate these wires and catheters using a 5G network. That is clearly doable. Can we establish a network of robots tied to our stroke center where remote mechanical thrombectomy can actually be performed? So sorry for the delay in the beginning. Let me just stop there and not show the rest of these slides, and then we'll show you the case. So any questions you want to ask about this?
Thank you very much, Alan, for finishing in time and giving us an overview. I think it becomes even more relevant in this era where, patient safety and very few people in the cath lab without,
Yep.
Getting in there, it becomes even more relevant. And I'm sure that this technique and this is going to grow in our country. At present, we have just a few systems in the country, but I think this is the future.
So this slide I'm showing you at the moment is our setup where we're testing this. This is a hospital 50 miles in the Methodist system where we hook the robot up to a simulator, and we can actually, because the important things are things like latency, what's the response time, and this is a setup where we can actually test this. So we think this is eminently doable at the moment. It will only get better.
And as time passes, I think more and more complex cases can also be done, because in the beginning, it's difficult to do very complex cases. We're used to, having people and this and that. But I'm sure that parallel technology in PCI or other procedures is also going to progress.
So do you want me to show this case?
We have about 4 minutes. Is that okay?
Okay, I think
sure.
We can brief.
Definitely, we'd like to see this.
We can cut it off. Yeah, I'll let it run. It's narrated.
Steering in order to access a fairly unusual type 2 endoleak in the type B dissection. Several principles will be demonstrated here. First of all is the importance of evaluating endoleak geometry using multiplanar reconstruction, angiographic evaluation of the flow patterns, the use of CTA to fluoro-CT fusion, which allows us to create a guidance system for the robot to deliver a septal perforating needle. This patient initially presented with the type B dissection. What's unusual, if you look at the inferior margin, is that the false lumen flows straight into the celiac artery, where the superior mesenteric artery comes off the superior mesenteric artery. Despite this, we opted to just go ahead and lay in an endograft in standard fashion, covering from the just beyond the left subclavian all the way down to just above the level of the celiac artery. And the patient tolerated this without any problems, no evidence of intestinal ischemia. A follow-up, however, they continued to have intermittent pain, and there's a very unusual flow pattern occurring within the margin of the sac, and you can see it depicted here. Now, this began high up in the endoleak sac. Began high up in the dissection and flowed inferiorly down into the superior mesenteric artery. And on multiplanar reconstruction, it looked like it was flowing from the superior intercostal artery straight into the celiac artery. And there was no direct access to the type B dissection and the false lumen directly at all. So for this reason, we opted to go ahead and take a somewhat unusual approach. And you can see how it flows into the celiac artery, but the SMA itself was flown off the true lumen. It's a little bit better, easier to understand this. Looking at the false lumen on the surface rendered images, where you can see the celiac artery narrowed, but flowing directly from the false lumen. On the workstation, we first of all did fusion of the previous CTA onto a cone beam CT performed on the table. And once this is done, it allows us to actually plan the route, and the route is actually planning is actually performed also on the workstation. First thing that we did was do an angiogram to evaluate the SMA, the celiac collateral. So you can see the SMA angiogram show that fills the hepatic artery and the superior mesenteric artery. On the workstation, we then planned the pathway. These yellow markers drawn on the computer will subsequently depicted on the fluoro system and overlaid on top of the patient. It's pretty easy to see the bottom end of the endograph. Here's the celiac artery. We can mark where the end-to-leak pathway is, and we can mark, you'll see a couple of X's that we're going to put on here where we really want to put a needle on the true lumen right at the bottom end of the graph straight into this end-to-leak pathway. And so when you step on the fluoro pedal, this is what is overlaid on top of the patient, and you can see it's very accurate. Where the catheter is in the SMA orifice here, injecting the SMA, and you can see the celiac is filling and the splenic artery is filling. And so what was done next, then we switch over onto the robotic control system, and here's the robotic sheath, which is being positioned right at the determined target, right in this area here. We then advanced a needle, which was perforated through the septum. This is a balloon which supports the needle. The needle is a 4mm throw, and you can see it coming right at the bottom of the endograph. When you advance the wire, it goes straight up and into the end-to-leak pathway. And you can see the wire is actually passing up this predetermined pathway, which we'd also marked and overlaid. Once you do that, you can actually put a catheter up in it, and you can inject. Almost looks like an artery, which is formed inside the false lumen. We then tracked a 4 French catheter over the wire. There's an 014 wire which had been advanced up into, and this allowed us, there's a 3D overlay, started to lay coils from almost the very top of this persistent end-to-leak.
So that, that basically is the essence of the case right there. Let me just save you some time and stop at that point and see if there are any questions.
That was a very good, very good demonstration of robotic endovascular intervention. What intrigues me is I think the most of the robots, especially the corridors, works on a 014 and 018 wire, and many of the endovascular interventions we do are on 035 wire. So is it compatible with 035, or we have a, or is it going to be the future?
It depends which one we're talking about. If you're talking about Corindus, no. Hansen was. They're working on an 035 system. And I mean, there's a whole new, what's happened with Corindus is it's kind of gone quiet for a little bit because Siemens have bought them. They're putting a lot of resources into it. And it was up front, it was a rapid exchange system only. They're going to come out with an over-the-wire system and a telescoping tube-in-tube system that will be particularly apropos for the carotids. So stay tuned. I think you're going to see a lot of developments in the next 6 to 12 months.
Thank you very much. And Dr. Allen, we would be having more association with you both at the society level and at Apollo.
Thank you. Apologize.
To start this.
No problem. Thank you very much.
Thank you very much. Thank you so much. And probably you will be sharing Dr. Roger Grenald's session as well, his lecture, which is due